Well, thank you, Paul, for the invitation. This is not really true, no disclosure, because I really do have disclosures, but it's on my first slide. I didn't know I had to put a special disclosure slide, but it's shown on this slide right here. So this was never going to be a debate, so I think John was smart enough not to turn up, I think. So as an opener, I would state that CT remains and should be the first technique of choice for sizing the annulus for TAVR. But I do have a take on where 3D TEE might fit. As you know, a lot of the literature about comparing CT versus echo, whether it be 2D or 3D TEE, was all in the time when a lot of intra-procedural TEE was done. And as we know, that has changed quite a bit, and it continues to change, so that we almost do no imaging. For example, at Piedmont, we probably take 2 transthoracic pictures, couple at the end, to make sure there is no obvious PVL, severe PVL, or pericardial effusion. I don't even go into the cath labs anymore, so it's a completely fluoroscopic procedure. So with that in context, I do want to provide a insight from our experience about where 3D TEE might still play a role. So let me see, where do I go? So we've taken the approach that for anything to work in the clinical environment, and especially with echo and volume data, and this might actually apply to CT and MRI, although they have been in the realm of radiology for so long, and radiology is so slow to move on things. Automation has never been their thing, although they are quickly learning the art of using artificial intelligence and automation in medical imaging. So I do think one of the approaches we have taken is a completely automated approach, because for this to work in the clinical environment, automation obviously has workflow advantages. So from a volume 3D TEE data, you can model the aortic root, including the annulus, either static in the phase that you want to model the annulus, or you can do a dynamic modeling as is shown here. This is a completely automated process. You acquire the data, push a button, and within about 4 seconds you get this volume data, from which you can derive quantitative parameters. So this has been the main thrust of why we think that automation is important if we are going to do measurements on any volume data, from which you can measure. This is again completely automated measure, just like CT would do. One would measure minimum and maximum diameters and an average diameter, which would be the average mean diameter. You can also get perimeter derived and area derived diameters, just like CT. What this slide shows is the other advantage of automation, and that is if we acquire 3 cardiac cycles and measure in mid-systole in cycle 1, cycle 2, and cycle 3, you can see you get very similar numbers, which is very reassuring in the clinical environment, because you make a single measurement, and I don't know how many of you have actually seen echo measurements, but we constantly change the lines until it fits what we think is the right one. So one of the problems of medical imaging, and that happens in the CT world too, it's done in the dark room, so you don't see it. In the echo, you actually get to see that manipulation of the line, so you tend to disbelieve the data more often than you disbelieve the CT data. However, it is important, I believe, to have some reproducibility that is reassuring within your own center or your hands, so that you can say this number is a reliable number. So that's the other advantage of using automation. So where does 3D TEE actually fit? And I think the place where it fits the best currently is in the planning of TAVR procedure, or in those small number of patients where intra-procedural TEE is still done as the only technique without a pre-procedural CT. But that's few and far between. Most of these patients who cannot have contrast CT because of elevated creatinine in our center now get a 3D TEE for annular sizing and TAVR planning. This is a precious technique because these patients don't have an alternative way of doing annular sizing. Perhaps a balloon sizing is another opportunity during the procedure. But 3D TEE does have a role in these patients. So I'll show you a couple of quick examples of how this works in our hands, and then show you some data in about 100-odd patients. So this is data in evolution. We are collecting this data right now to see how does 3D TE work with clinical endpoints in those who cannot have contrast CT. So this is a 66-year-old lady, severe aortic stenosis, high risk for TAVR, chronic renal disease, elevated creatinine, and this is 2D of the aortic valve, calcified, restricted valve, and this is the 3D. So this is a real-time volume 3D, so you could do this in patients with atrial fibrillation. There is no gating involved. This is like intuitive echocardiography. From any of these data right here, either in the short axis or in the long axis, you can model the aortic root, and from the model you can derive the minimum and maximum and the average diameter that is shown here. And then perimeter and perimeter derived, and area derived, much like what CT would do. This process takes literally a few seconds to do. It takes about 3 seconds to acquire the data, and it takes about another 5 seconds to get the quantitative data. So it really doesn't take much of a time to do this, either intra-procedurally or outside. We are still using the CT tables for sizing the annulus, although we get this from 3D TEE, because that was a test we wanted to do. And for example, in this patient, all three 3D TEE numbers point to a SAPIEN 23 valve. This patient underwent a SAPIEN 23 valve TAVR, as is shown here. And on the post-procedural echo, you can see almost no PVL. So completely guided by 3D TEE annulus sizing. This is another lady, a 50-year-old lady, unfortunate history, repeat mitral valve surgeries for failed mitral valve repair and bioprosthetic valves, has now got LVAD because of heart failure, intractable heart failure, severe AR, and also with chronic kidney disease. And this is, you can see continuous severe aortic regurgitation in somebody with LVAD. So this needed to be fixed, and TAVR was the preferred way to fix this. Again, no calcium in this aortic valve. This is the 3D TEE, short axis and long axis, with and without color, showing aortic regurgitation. And you can model that valve just like you take the mid-systole, and you can do this in a still frame quickly, and then obtain the minimum and maximum and the mean diameter and the perimeter and perimeter derived and area derived. And then using the same tables that CT would use, all three numbers predict a core valve 29, and she undergoes a core valve 29 valve and has no aortic regurgitation, purely guided by 3D TE sizing intra-procedurally in this case, because she had to be done under general anesthesia. And this is the post-TAVR TE showing no aortic regurgitation or no PVL. So just as a little bit of background as where we started this journey, this was a few years ago now. We first published this paper about 2013, and you can see what we did was to validate this automated TE approach against CT. And as you will see in this data, we actually compared both manual and automated, both for TEE and CT, using the same algorithm because it also works in the CT data. And one of the big advantages we noticed is in variability. If you can look, if you see the intra-observer variability is better with 3D TEE, but inter-observer variability is where we saw the biggest advantage in terms of using automated. This is manual here, this is automated. If you look at the variability data here versus here, you can see it's a very big advantage of using automated approach for 3D TEE. This benefit is also seen with CT. This is the current practice for CT, manual measurements, 2D measurements from a volume data set. And this is automated 3D modeling from CT. And CT again, even though CT manual is better than 3D TE manual, when you do automated approach, it does have an incremental value in terms of reducing variability, especially inter-observer variability, which is important in the real world because in the real world, we don't have trial data and core labs, but you have to depend on the skill and expertise of your own CT group. And that means to demonstrate intra and intra-observer variability within your own group becomes extraordinarily important to rely on those numbers. So here is the data thus far in our center. This is about a year's worth of data. We are collecting in those patients who are undergoing CT and 3D TEE. This is intra-procedural, although they have already been sized with CT. And this is done now in transapical cases and sometimes in subclavian approaches, but we don't do them routinely in transfemoral. Hence, it's been hard to find these patients. About 7 years ago, you could get this to be 267 in 2 weeks, but you cannot do that anymore because we don't do 3D TEE a lot, and we only do them when the approach is not transfemoral, or in patients who are high risk and are not eligible for MAC. So this is 67, and this is 3D TEE only. We have done about 50 patients with 3D TEE guided only without a CT sizing because of elevated creatinine and non-contrast CT, which would be not optimal for sizing the annulus. The only difference between these two groups, other than the numbers here, are there were far more patients with pure aortic regurgitation in the 3D TEE group because some of these patients had LVAD and severe continuous aortic regurgitation. So that was the only statistically significant difference between these two groups. Small numbers anyway, but there was a statistical significant difference. In all other parameters, these two groups were very comparable. Please note that the mild PVL was the rule, less than mild PVL, sometimes no, or trace PVL, whereas greater than mild PVL was seen only in a small number of patients, whether it be a CT approach or a 3D TEE only approach. The PVL rates were very comparable, and the core valve and the sapien valve breakdown is shown here, both for greater than mild PVL and less than mild PVL. We looked at the degree of calcification, and part of the reason for doing this is we wanted to see if automated modeling by 3D TEE would really work in the setting of severe calcification. And in echo, it's very hard to measure calcium because it's ultrasound bright. You can make anything look bright on an echo. But we did use a grading system, which had been described previously in this paper, where we went from grade with 0 calcium to a spotty calcium or isolated calcium with a little more, and then extensive calcium, and this would include also the LVOT calcium that you see here. So we had about 50 of the 100 cases that had 3D TEE, but half of them had grade 3 or 4 or significant calcification, and about a third of them had a grade 4 calcification. This would be extreme calcification, including LVOT calcification. For contrast CT, and this is a big challenge, it's easy to do calcium measurements on a non-contrast CT. But contrast CT measurement, which is standard approach in TAVR patients, it has not been standardized, and it would be nice to have John Lesser here because he would be an expert on this subject. I am not. But our PhD guy who works with CT came up with a method to measure volume of calcium. So we looked at the range of calcium in all those 67 patients who had CT, and it ranged from 0 to a volume of about 540. The median volume of calcium was 37. And we took a double of that number as a definition for extreme calcification of the annulus that included LVOT calcification. And about a third of them had extreme calcification by CT, very similar to the TEE number that you see here. And this is important for feasibility of using the TEE approach if you cannot do contrast CT. And it has implications for CT also. So here is the data. These are patients who had CT and 3D TEE. This is 3D TEE only. And if you look at if you look at this is patients who have had CT and 3D TE, I beg your pardon, and in the same patient. If you compare the CT numbers, mean diameter, perimeter derived, area derived, and the cover index derived by 3 different approaches, all of these numbers are significantly greater than the 3D TE approach, making the point that 3D TE always seems to measure a number that is smaller than its corresponding CT number, which is not a surprise, and nor we were surprised about that because we use the leading edge technique even in automated modeling for tracking. Therefore, we would see a smaller number than CT. So that is something we expected to see. But clearly, if you're going to use 3D TEE as your predictor for sizing the valve, we have to use a higher cover index number than we would use for CT. That's an important lesson to keep in mind. This is the correlation between CT and 3D TEE in those patients who had both techniques. Good correlation for mean diameter, perimeter derived, and area diameter. These are Blanda-Altman showing the bias and the limits of agreement. The limits of agreement here you can see the TEE consistently has a smaller number compared to the CT, but the limits of agreement are well within clinical acceptance. This does not seem to make a difference in sizing the valve, whether it be CT or 3D TEE. These small limits of differences between the techniques do not change the size of the valve if you use the CT table. So 3D TEE is viable alternative to CT. But what about those patients who only can have 3D TEE? What would be a good way to look at the efficacy of those patients? I mean, because they don't have a CT. So we looked at PVL as an outcome in these patients who had both CT and 3D TEE and 3D TEE only. The data here is for those patients who had CT and 3D TEE. So here you can see in the CT group, the cover index is shown on this axis, and the annular size is shown on the x-axis, and the actual valve that was used in these patients is shown here. And these dashed line here, these dotted lines, are the boundaries for selecting the valve size based on the CT table recommended by the manufacturers. So if you look at patients in whom 23 valve was used, the annular size and the CT measured annular size predicted the valves correctly. And similarly, in patients in whom 26 valve was used, with the exception of this patient, all the patients were predicted rightly by CT. And similarly, in patients in whom 29 valve was used, core valve, almost all the patients fitted the CT prediction. And in the patients with large annulus, 31, almost all the patients except these 2 patients here were correctly predicted by CT. What do I mean by correctly predicted? We looked at PVL, immediate post-procedural PVL. This is none, this is mild, and this is greater than mild or moderate and severe PVL. As you can see, the vast majority of them with correct prediction had either mild or no or trace PVL. There was only one patient here, and we'll come to this in a minute, where the CT said we would use a 26 valve, and we used a 26 valve, and yet there was moderate PVL. In the 31 group valve size, there were 2 patients where CT predicted a 31 valve, and yet they ended up with greater than moderate PVL. This is the core valve data. Similarly now, when you look at the 3D TEE only, these are patients who could not have CT. Unlike the CT data, you see that vast majority of the patients, for example, the 26 valve, they fitted in with what would have been predicted by 3D TEE. The actual valve size was 26, save this patient right here. In the 29 valve group, however, you can see about 50% of the patients had a larger valve than was predicted, or a smaller valve than was predicted by 3D TEE. So clinically, these patients ended up having a smaller valve. And then in the 31 valve, which was put in these patients, the TE predicted 31, but there were 2 or 3 patients in whom the valve size used was actually 29, and in 2 of these patients where the valve size we used was 31, there was greater than moderate PVL. So TE seemed to do a little worse than CT in terms of picking the right size of the valve, with PVL being the outcome or PVL being the clinical endpoint. With the SAPIEN, we did not see a difference between either CT predicted valve size and the actual valve size used and PVL as the endpoint, and either in the CT group or in the 3D TE group only when we sized it with 3D TE modeling. So we needed to find an explanation of why there was a discrepancy with the core valve. If you look at these patients here, where the CT predicted a 31 valve, and the 31 valve was indeed used in these patients, 2 of these patients had moderate PVL. If you look at the calcium annular score of this patient right here, that was 542. That was extreme calcification. That was in fact the highest calcium volume that we have seen in our patient. This patient here turned out to have pure aortic regurgitation and no calcium, and we believe that the actual valve size would have been 34, and which was not available at that time, and we suspect that if you had used a 34, this would not be a mismatch and it would be a right valve size. So that is the possible explanation here. This patient right here, where CT predicted a 26 valve and a 26 valve was used, the calcium score was high, greater than 70 was considered extreme calcification, and it was 120. In addition, the 3D TE data also predicted a 26 valve. So we suspect this PVL was due to extreme calcification and not due to a sizing issue. And that is a real world issue that we have. It is not only about sizing, but also about the extent of calcium, as we saw, as we heard in the discussion leading up to this presentation. If you now look at the 3D TE data group only, these 2 patients that had greater than moderate PVL, although they had a 31 valve, this patient had a bicuspid aortic valve, a dilated root, and by echo had severe calcification on pure and aortic regurgitation. So we suspect that the patient probably was not an optimal candidate for TAVR because of bicuspid aortopathy. The other patient here also had severe calcification by echo, and we suspect that the calcium had to play a role in causing significant PVL post-TAVR in these patients. And there was a comment about incomplete expansion of the valve after the valve was deployed, even after post-balloon dilatation. So if you actually look at the CT data, it so happens if you compare the CT predicted valve size and compare it to the actual valve size used for the core valve patients, almost all the patients were predicted correctly by CT. There were only 3 patients in whom CT predicted a smaller valve size than that was actually used. And even in these patients, however, the PVL was none or trace. In the SAPIEN valve, the same. The CT did extremely well in terms of predicting the annular size, with very few patients in whom there was underestimate by CT, and yet the PVL was not that significant. And these are some causes of the specific discrepancies that we saw. Interestingly, in these 2 patients where CT predicted a small size and a bigger valve size was used, this was CT predicted valve size. Here, these 2 patients, and these were the actual valve size used. The 3D TE predicted 23 and 26, and the end result was trace PVL and no PVL in these 2 patients. So the converse also seems to work sometimes, and that is TE can also sometimes predict a bigger valve size than CT. It's not always in one direction. What about 3D TE? Here is sizing of the 3D TE using the perimeter-derived annular sizing for core valve and versus the valves that were size that was actually used. If we look at the appropriateness or the match, it was only 63%. That was not very good, and it seriously underestimated the annulus in about 13 patients, even though they didn't have significant PVL post-procedure, but this was of some concern. Whereas in the SAPIEN, the same method did not cause any significant underestimation of the annulus, nor was there any significant PVL post-procedure. So the 3D annulus sizing as a sole method in those patients who cannot have contrast CT seems to work very well for patients undergoing SAPIEN valve TAVR as opposed to core valve, where using the perimeter, and this was the same result for the area also and for the mean diameter. So we then went back and looked how we might explain this. And when we went and looked at the causes of discrepancy, one thing that was always seems to happen is when we looked at the causes, there was a look at the sinus of Valsalva diameter that we did not include in our valve sizing by 3D TEE. And that was an important factor in undersizing for the core valve. And we also tried to match that with balloon sizing in some of these patients, and yet we underestimated compared to the balloon sizing. So we then included the SOV diameter, which can also be automatically measured by the 3D TEE by the same modeling method. And when we included the SOV diameter for 3D annulus sizing and predicting core valve size, the appropriateness or the comparison between the actual valve size used and the 3D TEE predicted valve size dramatically improved from 63% to 80%. There were still 7 patients in whom there was an underestimation, but now these patients had none or trace PVL, as you can see here. And with SAPIEN, even the few patients that were underestimated without including when we used the biggest diameter from 3D TEE, whether it be by area or by mean diameter, it completely excluded the underestimation. So it looks by 3D TEE, when we're using a core valve, the best thing is to use an annulus measurement and a sinus of Valsalva measurement to best pick the valve size as opposed to CT. So in conclusion, I think the 3D TEE is a very viable alternative in those patients who cannot have contrast CT. One of the important things to remember when we are using core valve is to include the sinus of Valsalva diameter in the prediction formula. And in SAPIEN valve, that is not an issue. And using the biggest 3D TEE diameter seems to predict the right valve size, with PVL being the endpoint. These are small numbers in a single center experience, but I do think we have gained some valuable insights in the real world challenge we have in those patients who cannot have contrast CT.
Excellent talk, Manny. So knowing that even small amounts of contrast can be harmful, how often are you using TE-guided only TAVR in your practice?
Only in those patients where the creatinine does not allow them to have contrast. Otherwise, we do use.
You still prefer CT?
Yes.
If they can get contrast?
Yes.
Okay.
Because we still need to do access anatomy and so on and so forth. So.
Well, I asked that because we've taken your lead on this, and so what we've done is we've done IVUS for the periphery, no contrast IVUS to assess the iliofemoral system, and then use TE to guide the TAVR procedure. So there's no contrast given from CT whatsoever.
Interesting.
So it's just an interesting take on that.
Yeah. That's interesting.
Yeah.
Manny, can I ask you a question? So you know my echo guy, Steve Little, and if Steve does my 3D measurements, I trust him implicitly. I'm happy to work with him. But what's always bothered me is that for every trial case we do, I do the Remencio myself, and I look at the measurements and I come to my personal decision of how we're going to do this and what valve we're going to use. The problem is that to look at 3D TEE, I need Steve to do it. Is this something that Steve could store in an echo and teach me how to do, or is it something that has to be processed as the echo is being done?
So you mean the specific method I showed, or you
any of the methods? I mean, so we can take a disc with a CT, and I can do post-processing 3-Mencio on it myself and make a decision. But could Steve store all this data on a disc, and then I do the post-processing if I had the software, or does it have to be done contemporaneously?
The answer outside of a specialized program like this is no. You have to be there when it's done.
So I think hi, that was a great presentation, by the way. So
thank you.
I have a similar sort of question, but I think what you were showing were the Siemens prototype. Similarly, the problem is it's not standardized, like Tremensio is standardized for us. So there's like a Philips QLab, which is the kind of software program that probably your TE guy and my TE guy, George Gellert, uses.
Yeah.
And so you can store the data sets in a stick and then reprocess them. But you're right, it requires a lot more of the X, Y, and Z axes that Tremensio automatically picks for us are not picked, especially in QLab. And that's my challenge. And I end up getting numbers that are completely outrageously out of line from what we get in Tremensio. So there's, I think, a learning curve when we use at least the QLab software. My question to you is, it seemed like it was pretty simple, and you said it takes less than 10 seconds. So is the Siemens program better?
In my book, and I know I have a conflict of interest, which I declared, there is absolutely no question that an automated software is much better than any expert manual. I can tell you the same data set looked at by two experts drawing lines on a fuzzy boundary give you two different numbers. It is simply not clinically viable. In a single hand, in a single center, who have hours to spend drawing these lines, and goes to the Mike's point, if I give you the software, and by the way, this software is not prototype, it's in the machine. We've been using this clinically for the last year and a half. So it's available for anybody to purchase. It's no more prototype. It's validated, it's out there, so we use it. So it is used clinically. But the point you make is very important, and I think manual measurements, especially on echo, is the variability is so high, and it is time consuming. And you can never seem to reproduce that data. CT is a little bit better in terms of manual method reproduction, but even for CT, I say, why don't you use an automated one? And if there is an automated software available, which it's available for CT, but they seem to be reluctant to apply that. But to Mike's point, all you need is a volume data from 3D TE, and if you can run the software on the machine, you can do this in the either in your office on offline, using the 3D TE data, or you can do it intraprocedurally. It takes a few seconds to do this thing from the time you acquire the data.
Well, it's hard for surgeons anyway, Manny, because I get distracted by all the pretty colors. So,
So basically, the volume acquisition is technically simple.
Very simple.
Yes, and that's basically what you're saying. It's like CT. You push a button, and it's acquired.
Yes.
It's
and then
not,
you push another button, it gives you all the quantitative data in about, I don't know, 6, 7, 8 seconds. I mean, 10 seconds, it's done.
Siemens software. So it does everything.
But that is the only automated software.
There's only automated software in
Yes.
Siemens. Other companies don't have an automated.
Right, although Philips is onto an automated software, they're all becoming automated. I think automation is going to be key when you're handling volume data, especially TE data, because it's too much data. You cannot be drawing these lines in X-plane and Y-planes, etc.
There was one number that I was struck by. More than 30% of your cases were post-dilation. Is that almost a routine? I mean, maybe an unfair question for you because you're presenting maybe the interventional cardiologist data, but there's like post-dilation in 30 to 40%. Does that mean that you guys are underestimating in both technologies, CT and TE, or is this just a routine?
It's a routine.
It sounds like a core valve site.
Yeah. Yeah.
Has been a routine.
We use a lot more core valves than we do with
Okay.
along with the fact that none of us accept any PVL anymore. I mean,
Yeah,
we used
so
to look, that's great. We're
they post-dilate to make sure there's no more PVL.
If there's anything at all, we're going to post-dilate before we leave.
Question?
Hi, Dr. Vannan, great talk. I have one comment and one question. One comment I was going to make was for calcium scoring, you have to use a non-contrast CT because you use a maximum intensity projection, and if you have contrast, it's sort of as an error. My question was because the methodology of measuring the annulus with the TE and CT are entirely different, because if you look at the CT, it is a virtual annulus created by notice of the points we put on 3 cusps, and we create a virtual annulus. But if you're doing with a 2D TE, you create 2 orthogonal planes, and then you make an annulus. So those 2 annulus are entirely different. But I was interested in your program because this one creates...
Go slowly and help a surgeon here and tell me why. I understand the CT. So tell me what you had to say of 2 orthogonal planes.
It is
And
correct.
what are you marking as your spots? Are you
So
marking-
here, if you put two orthogonal planes on a 3D TEE,
Yeah.
you're not anymore doing the nidus of the cusps, which is the CT virtual analysis. So those two planes are different, meaning you can have one cusp lower, let us say,
Yeah.
and the other two cusps, you'll have a plane like this. But if you were to take a three-dimensional plane of TEE, you take one line in parallel, let's say, to
So you don't get a plane that cuts the bottom of all
there
three
are two
cusps?
different planes, is what I'm trying to say. Because a 3D CT is on a 2D TE or two different planes we're measuring.
No, but
But
that's if
eventually-
you're using, that's, I beg to differ, because that's if you're using X-plane on 2D. But we're not using X-plane in 2D.
I think that's the point he's trying to make, I
Yeah.
think.
Yeah.
is-
Yeah, so we're not doing 2D. 3D imaging
Of course,
on QLab is 3D.
I understand the 2D part, but the
Even,
3D part.
even on
really-
3D on QLab, you have to create a plane to measure the annulus. How did we get there? We have to get there by giving two orthogonal planes, correct? Because how did we get there? Because we have to have
May I clarify? Yeah.
Am I-
Before you, don't forget your question though, because I think you had a question. So, when we say 3D TEE, there is a problem there because many of us end up doing, and not many of them, at least in publications, they say 3D TEE. But if you look at what they did, is they measured two 2D orthogonal diameters. They didn't really measure a 3D diameter. I mean, that is on a 2D cut from a 3D volume. That's not the same as a 3D diameter. For example, a perimeter or an area, right? But you can do a perimeter or an area from the same volume data set.
That is correct.
So,
But are we? My point being that it's not the same replication of a CT data with the cusps and the virtual
Agreed.
analysis created.
when you do it, when you take 2D extracted out of 3D, it's not the same. I
But
agree.
in your case, you're doing it exactly what the CT does.
Correct.
So that's what the thing I wanted to highlight. I've never seen this software before, but I think it's an excellent way of putting it forward. And despite this, it's underestimating it, which came as a surprise to me. Previously, I used to
But
think-
remember, it is still an echo problem. It's an ultrasound issue. There's nothing you can do. You can do 8D if you want, but it is an ultrasound, right? Because in ultrasound, we have to track something for automation. And we track the black-white interface, which is the most reliable one. If you go inside the white, it's all shades of gray. And then we run into a problem of unreliable tracking. So it doesn't matter whether it's 3D or 2D. I think the numbers will be always a little smaller than CT. What we learned from this is that because of that, the cover index you would use to predict a valve size has to be greater than a CT for an equivalent. So we have to recreate tables for 3D TEE and not just use the 3D TEE alone, the CT tables. So, but our numbers are small to recreate a table, as it were. We are hoping to get more numbers in before we recreate a table for that.
All right, well, that concludes this afternoon's session. Thank you very much, everyone, for attending.